this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. On this week's video, we're continuing with our ongoing series entitled The QME's Championship Playbook. And in this program, I'm sharing with you some of the very best secrets of some of the very best qualified medical evaluators of all specialties in the entire state of California. Any one of these procedures that we're sharing in this program, the QME's Championship Playbook, can dramatically change and improve your QME practice and your QME reports instantaneously if you'll just implement even one of these simple procedures. And once you get one procedure implemented into your normal routine, then implement a second procedure and a third procedure and a fourth procedure. And as you continue to implement these procedures into your normal protocol, you're going to see your end product, which is your QME report, your end product, your finished product, which bears your signature and which represents you out in the marketplace. You're going to see your end product improve dramatically in both the quality and content of your reporting. And today, as we continue in this series, I want to talk to you about diagnostic studies in your QME practice. But before we get into today's topic, let's just briefly review where we've come so far. And this will serve as a brief review for those of you that are following along with this series. And for those of you that are just tuning in on today's discussion, perhaps a quick review of these topics might spark a reminder in you about some certain need that you've come across or a certain need that you've had either in the past, present, or maybe even in the future related to your examinees. So this is entitled the QME's Championship Playbook, and the overriding purpose of this program is to have your QME report done in fabulous and meticulous fashion and get paid for that report within 30 days of the face-to-face evaluation of your examinee. So let's just elaborate on this for just a minute. As you know, we're required by law to submit our report within 30 days of our face-to-face evaluation with the injured worker. Well, we then typically expect payment for that report within 60 days of the date of the report. And many qualified medical evaluators are getting their report out on the 30th day and then are getting paid or are waiting to get paid until an additional 60 days beyond the date of the report. So this is potentially, in best case scenario, this is potentially a 90-day wait for payment on your QME evaluation. And I submit to you that it's possible and it's entirely feasible to expect to get paid within 30 days of the face-to-face evaluation. And this might sound impossible to you, but I'm here to tell you that it's entirely possible. In fact, you should expect it. This is something that you should shoot for. This should be your goal. And the procedures that I'm sharing with you in this program are the procedures that the very best evaluators use to do just that, to get their report out, to have it represent a fabulous end product, and number two, to get paid for that report immediately from the claims adjuster. And that may sound too good to be true, but I'm going to share with you many ideas that will collectively convince you that not only is it possible, it should be your goal with each and every report. So we started in session 1 of this program talking about the QME preparation for success. And we said that preparation for success begins at the 2 to 3 week before the face-to-face evaluation. That's the point in time when you begin ramping up your procedures so that when you actually get to the face-to-face evaluation, the evaluation is almost completely done. All you need to do at that point is sit with the examinee and take the history and do the physical examination, and your report, by the time you get to the face-to-face evaluation, is 70, 80, maybe even 90% complete. This is way different from the way typical QMEs approach the face-to-face evaluation. In our second session, we talked about preparation, QME preparation again. This time we focused on the cover letters and the medical records and how to extract the complexity factors from the cover letters and the medical records that you receive. So that was an invaluable discussion. In our third session, we talked about QME preparation, how to prepare your template, how to prepare your exam, how to prepare your diagnostic studies, and how to prepare your own mental focus in the 2 to 3 week period approaching the face-to-face evaluation. Session 4, we talked about the review of records and how to qualify your review of records as a complexity factor under CCR 9795. And I must tell you that most doctors, their review of records section in their report is deplorable. It's deplorable. And I can say that because I have the opportunity to read and review many doctors' QME reports, and the review of records section is terrible. Let me give you an example. Many QMEs, if you can believe this, do not organize their review of records in chronologic order of the records. Okay? What would be one of the most basic principles in presenting your review of records in the body of your report? Shouldn't it be, number one, most basic, at least put the records in date of order that events occurred chronologically in real time? Many doctors simply do the review of records with no chronology at all. They simply review the records by provider. For example, they'll review a stack of records from the hospital, another stack of records from the therapy department, another stack of records from the chiropractor, and will never take the time to collate those records in chronologic order from first events to most recent events. So if you're not doing that, this is something that you can begin to do right away on your very next evaluation, which will instantaneously improve the look, the content, and the quality of your report. And that's just one idea related to review of records. In our next section, session 5, we talked about how to establish the tone of the evaluation. And if you did not catch this section, you should go back and look it up. It's called Establish the Tone of the Evaluation. And in this discussion, we talk about how to create an examinee, or how to create an atmosphere for the examinee such that the examinee relaxes, such that the examinee breathes comfortably, such that the examinee is comfortable, so that the examinee can be open, honest, and communicative with you. And there's an exact science for taking an otherwise tense and anxious examinee and calming them down so that they are cooperative, open, and honest with you for the duration of your face-to-face evaluation. So that was a valuable session, and I encourage you to go back and watch that one a couple of times so that you master each and every one of those procedures, some of which actually are required by law. Some of which are required by law. And I find that many doctors, most doctors, are not aware of the law, and therefore most doctors don't perform the actual procedures that are required by law. So these procedures are not just ideas, these procedures are required. So I encourage you to master each one of these, at least those that relate to laws. In our next session, we talked about the activities of daily living assessment and how to do an accurate activities of daily living assessment in the face-to-face evaluation. Again, a fabulous and valuable discussion. In our session 7, we talked about your physical examination, and we're going to touch a little bit more on that in today's discussion as well. And I should just reiterate that the physical examination that you perform in the permanent impairment evaluation in other words, in your QME practice, is much, much different from the physical examination that you employ in your clinical practice. So the principle is to know the impairments, and this is a quote, know the impairments and examine for them, unquote. And I'll touch a little bit more on that idea as we go through today's discussion as well. In our next session, we talked about the formal gait analysis. In our session after that, we talked about the non-physiologic examination. In other words, how to incorporate non-physiologic examination maneuvers into your routine physical examination protocol for the assessment of your examinee's credibility. And this has to do with the Waddell signs and other physical examination maneuvers that are either simulation maneuvers, that are distraction maneuvers, or that are maneuvers that should not otherwise cause pain, but the examinee doesn't know these things about these maneuvers. In our next to last session, we talked about the pain behaviors and pain-related impairment. And really, pain behaviors is a fascinating topic. The interesting thing about pain behaviors is that pain behaviors are nonverbal communications from our examinee. They're nonverbal. So in many cases, bona fide pain behaviors are true objective findings for active symptomatic conditions. So pain behaviors, you can think of those as true objective findings. So anytime we encounter an examinee, we have subjective things that they tell us by way of their testimony, and then we have objective findings such as our physical examination findings. Well, pain behaviors contribute to objective findings because pain behaviors are true objective findings in the presence of bona fide symptomatic conditions. It's fascinating. And many examinees will have their pain behaviors corroborate their description of subjective complaints and activity limitations, and other examinees will have an absence of pain behaviors which tends to conflict or contradict their subjective statements. So that was a fascinating discussion. And then in our last session, we might have jumped the gun a little bit on this, but I wanted to get it in there and talk about the analysis of motion segment integrity for those qualified medical evaluators that examine spine-injured examinees. The analysis of motion segment integrity is probably the most overlooked of the permanent impairments in the entire book, the entire AMA guides. Certainly within the spine chapter, the analysis of motion segment integrity is largely overlooked as a potential impairment in your examinee. So I encouraged you to get familiar and get fluent with the process of analyzing for loss of motion segment integrity and incorporating that into your routine practice, procedure, and protocol with each and every spine injury case. Okay? So that brings us to today's discussion, and today I want to talk to you about ordering diagnostic studies. Now, the AMA guides in many cases require diagnostic studies, and discussions of diagnostic studies are replete in every chapter of the AMA guides. For the purposes of this discussion, I want to limit our discussion mostly to chapters 15, 16, and 17. Now, in chapters 15, 16, and 17, the AMA guides describe many different types of diagnostic studies. So, in order to develop this point, let's just talk about what are those diagnostic studies. Well, in chapter 15 of the AMA guides, diagnostic studies that are discussed within chapter 15 include EMG, electromyography, cystometry, which are bladder studies, X-ray, we'll talk more about X-ray here in just a couple moments, CT and MRI, both with and without contrast. So those are all discussed in Chapter 15. In Chapter 16, they talk about X-ray. They talk about EMG/NCV. So here for the extremities, we include diagnostic studies for the assessment of peripheral neuropathies through the use of nerve conduction velocity testing. They talk about bone scan, talk about laser Doppler, they talk about arthrogram, and again they talk about MRI studies. And then in Chapter 17, diagnostic studies that are described there include EMG and NCV, Doppler vascular studies, X-ray studies, MRI and CT studies, and bone scan studies. So the purposes of these diagnostic studies is twofold. Number one is to help us establish the active condition in our examinee, and then secondarily, or I should just say number two, many of these studies are required, all caps, required, for the assessment of the impairments that are described in each of the respective chapters. So for example, in Chapter 15, when assessing for spinal impairment, let's just talk about the use of X-ray studies and its use in assessing impairments. How are X-rays used in Chapter 15 to assess for impairments of the spine? Let me ask you, can you think of any use of X-ray for the assessment of impairments of the spine? Well, as we talked about in our last session and we just alluded to, X-rays are required for the assessment of loss of motion segment integrity. The AMA guides provide generous impairment when there is a loss of motion segment integrity of the individual vertebral segments of the spine. It represents a significant loss of function of the spine to have an upset in the biomechanical function of the individual spinal segments. The AMA guides refer to this as a loss of motion segment integrity. Well, in order to assess for this, the AMA guides tell us that flexion and extension radiographs are required. They're required. Now, many doctors in assessing spine injury cases do not take the time, effort, and energy necessary to order these studies. But it's required. When you have spine injury cases, you must assess for loss of motion segment integrity. So the diagnostic studies are required. And the point that I'm making is that the AMA guides require diagnostic studies for the assessment of many impairments. So you need to become familiar and comfortable and fluent with the process involved in getting the diagnostic studies, which is no easy task, and we'll talk about here in just a couple more moments. What else in Chapter 15? How else are X-rays used? Well, X-rays are used for the assessment of acute or late effect of fractures. And acute and late effect of fractures qualify as impairments in Chapter 15. We also use X-rays to help us identify pre-existing conditions, anomalies, degenerative changes, or any unusual findings, aside from a normal spine, that we may encounter in the spine. So how does that help us? That helps us to identify potential impairments. It also helps us when it comes time to discuss causation. It also helps us when it comes time to discuss our apportionment determination. We'll talk a little bit more about that in just a second. So many uses for X-rays just in Chapter 15 alone. What about Chapter 16? And here we're limiting our discussion just to X-rays. I'm just talking about some of the many uses just of X-ray that are described in these three chapters. Well, in Chapter 16, X-rays are required to assess for ankylosis, one of the upper extremity impairments, at least by analogy. Number two, it is required for the assessment of trophic changes of bone associated with causalgia and chronic regional pain syndrome. How else are you going to identify trophic changes of bone without ordering the appropriate x-rays? X-rays are also required for the assessment of carpal instability. So in those cases where you have wrist and upper extremity injury cases, if the examinee complains of any symptoms involving the wrist, and they've had an injury involving the wrist, you must assess for the presence or absence of carpal instability. How do you do that? You do it off x-rays. X-rays are required. They're described in Chapter 16. They're required. In Chapter 17, what are some of the uses for x-ray? Well, x-rays are required to assess for impairment due to post-traumatic arthritis. How do we do that? We measure the cartilage intervals at the hip, at the knee, at the ankle, and in the foot to assess for loss of cartilage interval associated with post-traumatic arthritis. Many doctors do not assess for arthritis in their lower extremity cases, and they're doing the examinee a great disservice and perhaps overlooking impairments that the examinee may actually qualify for if you would only follow the AMA guides and do what's required by the AMA guides. We use x-rays in Chapter 17 for the assessment of limb length discrepancy. Limb length discrepancy. Now, we have some physical examination procedures to assess for limb length discrepancy, but the iron-fast assessment, the ironclad assessment for limb length discrepancy rests on x-ray findings of unleveling of the pelvis due to one leg being asymmetric with the other leg. So x-rays are required for a definitive assessment of impairment due to limb length discrepancy. X-rays are required in Chapter 17 to confirm impairment due to gait disturbance. If you remember in Chapter 17, impairments due to gait disturbance require some form of objective imaging evidence of joint space narrowing on the x-ray, either at the hip, either at the knee, or at the ankle. Okay, so they're required. If you're going to provide for permanent impairment due to gait disturbance, there has to be an accompanying objective imaging finding of either, I think it's mild to moderate or moderate to severe degenerative change of the involved joint. Okay, and that's assessed by x-ray. X-rays are required for the assessment of ankylosis. They're required for the assessment of fractures. They're required for the assessment of bone changes associated with causalgia and chronic regional pain syndrome. And also, so those are some uses of x-ray in the assessment for impairments. X-rays are also important for the assessment many times of causation, AOE-COE, AOE-COE. In other words, sometimes the identification of an active symptomatic condition on x-ray is sufficient for you to opine FOR industrial injury, or sometimes the absence of a symptomatic condition on x-ray is sufficient to contribute to your opinion against industrial injury. So x-rays are important sometimes also in our causation determination, and similarly, x-rays are sometimes required in our apportionment determination as well, because as we now know, apportionment to pre-existing conditions and apportionment to pathology is now allowed. So in every single case, when you provide a permanent impairment rating, your apportionment determination is required. And many times, the findings on x-ray and other imaging studies contribute to your opinion on the apportionment approximate percentages. So this is just talking about x-ray. The AMA guides talk about many other types of diagnostic studies as well, But I focus in here on X-ray just to give you several examples, real practical examples, as to how the AMA guides perceive the use of diagnostic studies and how diagnostic studies are used, how we use diagnostic studies in fashioning our opinions on many issues, including causation, including permanent impairment, including apportionment, and this is not a complete list. Okay? So the point is that diagnostic studies are something that you need to become familiar with ordering. You need to develop a system for ordering these studies, a system that allows you to order the studies quickly, without a lot of effort, without a lot of energy, and without a lot of time involved. And you need to have a system that allows you to get the results that you need from the diagnostic study provider, to get you the results that you need quickly, get them on your desk quickly, so that you can get your report out quickly, so that you can get your report paid within 30 days of the face-to-face evaluation. Okay? So when it comes to diagnostic studies, how can we template and systematize this process to make it easy, effortless, and quick? And let me just tell you that when I talk to qualified medically evaluating doctors about diagnostic studies, as I said, many doctors do not order the necessary diagnostic studies. And they either don't order those studies because they have tried in the past and have found it nearly impossible to do, or they simply are not aware of the uses of the diagnostic studies required by the AMA guides, and for that reason they don't know what they don't know, and they don't order the diagnostic studies for that reason. Okay? So for both of those populations of doctors, you both need to become familiar and systematized in the process of ordering diagnostic studies, because they're required. Okay? Okay. So let's now talk about the process involved with ordering diagnostic studies. And in our very next section, in our very next discussion, I'm going to talk to you about a hypothetical case. I want you to imagine that you have a face-to-face evaluation coming up, and you've already received the records from your injured worker, from the claims administrator. So you have all the records, you know the main issues of the case, you have the face-to-face evaluation coming up in about 2 weeks. Now is when you begin to think about what diagnostic studies you'll be ordering. And the goal, and let me challenge you to see if you can accomplish this goal. The goal is to have the examinee leave your face-to-face evaluation with you and go directly to their appointment for the diagnostic studies. In other words, the appointment for the diagnostic studies is arranged far in advance of your face-to-face evaluation with the examinee. The goal is to have the examinee leave you and go directly to the imaging facility if you're ordering images, to the consulting specialist if you're ordering special studies, to the provider for electrodiagnostic studies. Whatever study it is you're ordering, the goal is to have the examinee go directly from you to the studies, so that you can get the results of the studies either the same day. Most times you can get the results of imaging studies the same day, or at the very latest by the very next day, so that you can then bust out your report and get it done and get it out and have it paid within the 30-day timeline. So I want you to imagine that you have such an evaluation coming up. What are the things that you can do in advance? What are the things that you should expect in advance? What are the steps that you can handle in this process of getting diagnostic studies in advance in order to allow you to accomplish that goal of having the examinee go either same day or very next day, or as close as possible in time to the date of the face-to-face evaluation. And this is going to be a fascinating discussion for you. And I can tell you If you'll listen to every step that I share with you in this discussion, it will simplify everything. Everything that I'm going to share with you is secrets that I and other doctors have learned through the school of hard knocks. And trust me when I tell you that ordering diagnostic studies and getting them done properly, and getting the results back on your desk in a timely fashion is next to impossible. And that's why many doctors don't do it. They simply just give up because it takes too much time, it takes too much energy, it's too much of a hassle to get it done. But if you just follow these simple steps and stay with it, I'm going to show you how you can get your diagnostic studies completed and get your report out either the very next day after the face-to-face evaluation or very close in time to the face-to-face evaluation. So we'll go over all of those steps in our very next discussion coming up here in just a few moments.